Hello, everyone. Thanks for your patience while we allowed others to join. For those of you that are just joining, my name is Casey Webb here at Valencell. We appreciate you being here today. We have a great presentation lined up for you. We're very happy to have Dr. Chris Eschbach, the director of Valencell's Biometrics lab, here to discuss clinical validation of biometric wearables and how accuracy drives compelling user experiences. Some brief logistics to cover really quickly. We do have an hour scheduled for the webinar today, and we've got about 30 to 40 minutes of content prepared for you, with the remaining time allotted for Q&A. If you do have questions during the presentation, you can submit those through the GoToWebinar interface. We'll collect those and address them as we go along. We do always get asked, will the presentation and slides be available after the webinar? And the answer is yes. We will be sending both the slides and the recording to you following the webinar. And with that, I'll go ahead and turn things over to Dr. Eschbach.
Hello, good morning, afternoon, and good evening, whatever time it may be where you're at. Thanks for joining the webinar. Again, my name is Chris Eschbach. I direct the Biometrics laboratory here at Valencell. Today, we're going to overview some of the validation processes that we go through and follow within the laboratory. I'm going to give some examples of data that we see and accuracies and inaccuracies to that, and then highlight a few use cases. So with that, we'll start the presentation. If I can get the slides to move forward, there we go. Just an overview on this, biometrics based data can be used for the purpose of providing interesting, meaningful lifestyle, health, and fitness insights, including but not limited to assessments of health and fitness and quantification of daily living and training. And really my philosophy on this, when we look at something that's lifestyle, health, and fitness insights, I don't see a differentiation between something that is lifestyle, meaning everyday monitoring, including sleep monitoring or health monitoring, and fitness monitoring that we all know, from the beginning fitness to elite level fitness. I don't see any difference between those things. A lot of people try to separate them. They try to separate them as it relates to monitoring fitness or monitoring biometrics and even monitoring sleep and stress. But we are all under load on a daily basis, and that load may be greater or less than. But what is a 1 mile walk to one person is easy to one person, may be very difficult to someone else. And again, a 10-mile run may be easy to someone and very difficult to someone else. So when I think of all these biometrics across this continuum, it is a continuum, and it depends on where you're at. But we can have the use cases apply to all of them. This is what we're going to go over today. I'm going to go over a little bit of Valencell overview. I would expect that most of you know what Valencell is about. We're going to look at just a brief example of some data accuracy to get a little bit of a foundation. I'll spend a little more time on biometric wearable sensors and the validation that we go through here, and then go through 5 or 6 different use cases briefly as part of this presentation. So first, we'll start with the Valencell overview. Valencell really is this kind of systems approach. We are from the beginning, early stages in the optomechanics of sensor design to the endpoint in manufacturing and user experiences. We sorry about that. So we deal with optomechanics, and in Valencell, there's the sensor system can really take 3 forms. We have our benchmark unit sensor system, and we have several varieties of that. Something that is a benchmark, that's the name of our sensor system. So we have a benchmark ear that goes in earbud-based devices, and we have benchmark, which we call benchmark wrist, but it really can go anywhere else on the body. And that sensor system is optically based. It has LED emitters and, of course, detectors and the algorithms that go along with that to determine assessments of heart rate, assessments of heart rate variability, or R to R interval. We'll talk a little bit more about that later on. And then estimates of energy expenditure and oxygen consumption, other variables. We are working on non-invasive blood pressure measurement using these optical techniques. That benchmark unit is a unit that can be purchased by our partners, and then a product can be built around there. We also have relationships with our partners that are licensing arrangements, and partners that are using our patents to develop their own sensors, and that's a little more rare, but the first two are our primary case for Valencell. So we go through the optomechanics, we have the firmware algorithms, the testing and validation process, and again, that is the main thing that I'm in charge of. To overview the laboratory, what we do on a week-to-week basis in the operations of the lab, we have 90 or so trials per week, depending on what we're working on. And in those trials, on a weekly basis, we have 60 sessions, and those sessions are 1 hour long, and a session is one single person. We may have more than one person in the lab at a time. We have 60 trials a week that are part of our R&D efforts and our validation, and those go hand in hand, of course. We may be doing R&D on new sensor designs. At the same time, we may be validating reference designs or our partner designs. And then we have an additional up to 30 trials per week for other research trials, and that may include longitudinal data. We do some training studies here to kind of be thought leaders and monitor the biometrics over time, where we take people that are generally untrained and we put them through a physical activity regimen based on their fitness level and monitor them over a period of weeks and months. And then we do some resting trials, and that includes blood pressure, stress monitoring, in some cases sleep monitoring. We don't do sleep in the lab, but we may have them come in and teach them about the equipment that we have them use while they're sleeping. Within the lab, there's really 4 types of positions. There's the director, well, 5 types of positions. There's the director, myself. We have operations leads that's in charge of all the scheduling and the prioritization. We have our data lead that's responsible for moving the data, running different algorithms. We have our data science liaison, which is our reports lead, that is quantifying everything. And then we have our trial specialists, which are our primary data collectors. And then we have between 4 and 7 to 9 people in the lab at any time managing all of the people and data that's coming in. Now I want to give an example of some data accuracy here. We're not going to go way into depth with this, but this is an example. What you see along the bottom of this graph is time. This is a 55-minute exercise session. It includes a warm-up there that you see there on the left side, and then 3 10-minute intervals at the same speed. So what we see with the orange line on this graph is the heart rate from an optical sensor. The purple line is the speed of the trial. So you can see during the warm-up, they did a little step up there, and then they had 2 running speeds, and they walked. And they actually stood still there for just a little bit before they got into these 3 10-minute intervals. And what we see here is that the average heart rate for this trial using the heart rate from the optical sensor is 149 beats per minute, with an estimated calories for the 55 minutes of 682 calories. If we take a heart rate during one of the 10-minute intervals, we can actually estimate the VO2 max. So this is a sub-maximal. They weren't going all out, but it was a hard effort. They weren't going all out, but we can estimate VO2 max using some steady-state heart rate measures, and we estimated it 43. VO2 max is a measure of cardiovascular fitness. So we'd use it as an assessment. This person could be doing a workout, and at the end of the workout, or maybe a weekly summary, we could estimate their fitness so they can monitor that change over time. Now that assumes that this is just an optical sensor heart rate. We don't know anything else about it, And the reality is, if I move on to the next slide, is that if we really know what's happening without any kind of insights, without any knowing that this was real or not, it wasn't the real heart rate. What we see now here in the blue line is our reference device. It was a chest strap heart rate monitor, typical electrically based chest strap heart rate monitor. And you can see that it wasn't, the optical, which is in orange, wasn't truly tracking the heart rate. And it may have been, the poor algorithms, maybe in poor optomechanics, who knows what the problem was, but it was believable if someone didn't know any better. It was not correct though. So with the correct heart rate, an average of 161, we get 764 calories, that heart rate during this interval, 183, and a VO2 max of 39. So a worse cardiovascular fitness score. So it could have had a determined calories. If I go back, remember it was 682 versus 764, and an overestimated fitness, both of which then are detrimental to the person that's trying to rely on this data. They can't plan accordingly. Their fitness is overestimated, their calories underestimated. So it's important to be able to determine when something is accurate, and Valencell, in our sensor systems, we provide our partners with figures of merit. And one of those figures of merit is quality of signal. So our partners can utilize those figures of merit to determine if and when the quality of signal is not great, and determine whether we're providing an accurate heart rate or not. So I wanted to do this example just really to show that it's possible to kind of have believable heart rates that are not correct, and then that inaccuracy can lead to problems in the user experience. And then just finally, we'll look at the differences here, but the one line that I've added in here is step rate, and that was really the problem in this example. The average heart rate was 7.5% difference between the wrong heart rate and the real heart rate. The calories were over 10% difference, and the VO2 max estimate was over 10% difference as well, those are big differences, because as you change fitness, depending on what your starting level of fitness, from start to finish, you may not change your fitness at 10%. That's debatable. So using Valencell signal quality, we would have determined this. My theory is that using Valencell algorithms, we wouldn't have seen this as much during this situation, but I wanted to show one that was not going well. So the industry, and this came out, this was a statement in 2015, that the industry lacks clear methods for benchmarking accuracy, and this inaccuracy damages the reputation of the industry. And if we're not aware of what constitutes a good fitness tracker, then we'll suffer and these low quality trackers that we know that are out there. And it's not just, there are many low quality trackers that are out there, but it's also using the right tracker in the right use case, or really the right position of a good biometric wearable in the right use case, and we'll talk more about that in just a second. So the industry lacked a clear method of benchmarking accuracy. That's becoming less so because the Consumer Technology Association has a standards committee. I chair that standards committee. The Consumer Technology Association, if you don't know, is responsible for the Consumer Electronics Show that you of course know about. I want to highlight one of our standards, which is CTA 2065. It's physical activity monitoring for heart rate. You can download this standard for free right from the CTA website, and I have that there at the bottom, or if you just search CTA heart rate standard, you're going to be able to find that. Within that standard, it outlines the number of participants you need, what type of participants you need in terms of men and women, and for optical heart rate, different skin tones, different body compositions. It outlines 5 different protocols that you can use to look at the validation or the accuracy of a heart rate monitor. And this is not specific to optical heart rate. It's very actually kind of generic, and that was our intent, that any wearable or non-wearable that's measuring heart rate, if it's doing it for continuous heart rate, then you can use these protocols and these guidelines to determine the accuracy. It outlines data performance, and that data performance is in the, that data performance is in the realm of output rate. So is it coming out every second? Is it coming out once every 30 seconds? The data availability. So we do allow a percentage of time that the data is completely unavailable. And that might be during a time where the quality of signal is very low, and we know that the heart rate that's reported is not right. And that's more beneficial than not, because I'd rather not have the heart rate provided to me when it's going to be a wrong heart rate. That way I know that I can use the data that I have. Of course, there's an accuracy standard in there, and then a data offset or latency part to this standard. So you combine the participants, all 5 protocols and the data performance, and a biometric device that measures heart rate can meet the CTA standard for this heart rate. I encourage you to go there. I encourage you to use those protocols. If you have any questions about that, let me know. We're going to talk a little more about how we use it here. And then there's other standards. There's step counting, a very simple step counting standard. It's just during walking and running. There's a couple different sleep standards. And then we are working currently on stress monitoring standard, an activity intensity standard, and a mobile health application standard. And those are all in our current working groups right now. So it's pretty exciting to be part of that. If you are a member of the CTA, if your company is a member of CTA and you want to be involved in this committee, let me know, and I can give you some details. So a little more about biometric sensors and validation as it relates to my lab. Really, I talked about at the beginning of the presentation about that I think it's all a continuum, but the actual use case is not necessarily a continuum. We have people that are using biometric trackers for lifestyle situations. We're talking about activities of daily living as you go through your day. We have things that we call in session, so a specific event, and that may be an exercise session, or you can see a firefighter there, so it may be a call that they're on, and we're trying to monitor during a set period of time. And then, of course, more health monitoring for the health metrics, and that may be hospital or caregiver-based biometrics that they have interest in. Now, with these use cases, and within the use cases, there are many things. And you can imagine, like just in the in-session one, whether it's a military situation or across different exercises, you see someone there holding a dumbbell, riding a bike, running, swimming, those, and they're sleeping, those things require some serious thought about what would be the best practice to get the best biometric data from a sensor. And of course, there's a substantial form factor diversity in wearables. There's things on the leg. There's biometrics in jewelry and rings, in cycling helmets, armbands, and on the forearm or the upper arm. Of course, there's biometric wearables at the wrist, and Valencell started at the earbud. And what we wanted to do at the beginning Valencell was make it seamless for people. People already exercise with earbuds in. We wanted them to continue to do that. And not only are you going to get to hear your music, talk on the phone, you're going to get biometrics that are useful for your daily life in that. So depending on the use case, then it's important to think about where is this sensor positioned at. If I'm going to be doing a lot of upper body activity, I'm doing pull-ups, or I'm doing a lot of dumbbells, then a wrist-based sensor may not be your best bet. That there's a lot of blood flow changes in that situation, but an earbud will be great for that situation. And really, an earbud's probably one of the best. It is really the best place for a biometric sensor. The head is very stable. There's not a lot of random movement. Hopefully, you're not getting blood cut off to your head on a regular basis, or otherwise you're in trouble in that situation. But you've really got to think about, what do I want out of the sensor, and what is the position and the anatomy and physiology that go along with that location on the body. Very important to think about the use case. So what do we do at Valencell in the lab for our metrics collection? Of course, we collect a lot of raw data, pre-processed data that we're going to run different algorithms on. We are looking at metrics like heart rate variability, which is simply the millisecond time between heart rates. And that's not just as easy as inverting heart rate. You've got to have higher resolution on that, but it can be a measure of stress. We can measure steps, of course, when measuring stress, blood pressure, and then we can estimate things like calories, oxygen consumption, speed and distance, and that can come from the accelerometer, or it can come from GPS. We collect and we're monitoring this data. Of course, we're using baseline devices. What is our reference device? Our reference device for heart rate is a chest strap heart rate monitor. It is better, in my opinion, under a diverse range of protocols than an electrocardiogram. Electrocardiogram, when you really start to move around, those cords start bouncing around, give you a poor signal. ECG is the gold standard, no doubt about it. I can see that ECG tracing, I can look into it, but when in practical use, when you're doing heavy duty exercise or a lot of moving around, even its activity in daily living, then you've got to do a lot of prep, for that person to get rid of the movement noise for most part. So we do use a chest strap heart rate monitor. Those are great reference devices. For stepping and that sort of thing, we're doing video, and of course for blood pressure, we're doing manual and automatic blood pressure. For calories, we're doing metabolic cart. You see that in the upper right, indirect calorimetry. We have actually measured courses in terms of distance, and then we have treadmills and all the things that we need in the lab. I'll talk a little bit more about reference devices just briefly in just a little bit. So what are our tools? Well, our tools, number one, is a very wide range of participants. We have a diverse population of ages, body compositions. Fitness is pretty diverse. They're pretty average. They are active people. Like I said, to have that many, to have 60 or up to 90 people a week, we have a big list. We have an experienced staff, and they are experienced in all things connecting Bluetooth. They're experts in troubleshooting that. They're experts in being able to handle a variety of data that comes from the devices. It's not all easy. It's not all Bluetooth low energy heart rate coming off at 1 second data. So they are experts in being able to handle that and figure out what to do with it. So we have databases and data experts that overcome this data collection user interface challenges. And then for our data collection, we have multiple things. We collect raw data, and we have programs that allow us to do that. We also have an app that Valencell created, a custom app that allows us to collect multiple Bluetooth low energy devices, including Valencell reference designs. And if you have a Valencell reference design and you're not using this app, you should do that immediately, because it allows you to get the figures of merit from the Valencell reference devices. And I'm going to show you some screenshots of that in a minute. It's available right now only on iOS. It's available for free on the Apple App Store. Of course, in the lab, we have lots of exercise equipment. We also have lots of the ability to do lots of lifestyle or activities of daily living. You can see this picture in the upper right, wooden puzzles. We use that to mimic office or factory work, have them move their hands. We have people vacuum our carpet in the lab, which is awesome, stays clean. And then, of course, we have lots of reference devices, baseline and procedures, how to handle those data, what to do with the data, of course. Lots of things that are needed to collect all this data in terms of phones and the cameras to take pictures. You can see that one of my lab staff is taking a picture of an earbud in someone's ear. We're keeping track of how that earbud is. We also keep track of comfort and security. We have our custom programs, our custom database, but for many years we used off-the-shelf things. We used free apps online that allowed us to collect that heart rate data when we were still collecting raw data, but say from a chest strap, we were collecting from standard apps. So it's easy to do once you figure out exactly what you're needing. You don't need to have some sort of team that's going to create a custom app. It makes it easier, but it's not necessary. These are screenshots of that Perform Tech data collector, and I took these straight from the iOS store. And you can search that, and what this allows you to do, this app allows you to collect multiple Bluetooth low energy heart rate devices at one time. So if you're testing out or doing use case development for a Valencell powered reference device, that you can have that reference device in the app. And you can have a chest strap along with it too, or you can have two Valencell reference devices, an earbud and an arm device plus a chest strap, all three of them in here. You can actually control the modes of Valencell reference devices. So you can have it in our running mode or our lifestyle mode, and you can choose what figures of merit are going to be shown and collected during the trial. And in the end, you get here to the lower right, a CSV file is emailed to you with all that data in it. It has the heart rate of the multiple devices. It has the figures of merit, and you can run some statistics on all of that. Our quality of signal comes out in this app. So again, if you have, this is pretty new, only in the last couple of weeks has it been available on the iTunes store. It was before we had to kind of email you and test ferry, but now it's easy to use. You don't have to have a Valencell reference device. So if you're, just want a simple app to collect some heart rate data, you can do that, but it works best with the Valencell devices. So part of that process, there's areas for consideration. That CTA protocol mentions some of these areas for consideration, but you gotta, we test for optical noise, sunlight. We have sunlight protocols. We send our people outside, go through shadows and sun. We keep track of their skin tone using the Fitzpatrick skin tone chart. Of course, blood perfusion. We're measuring blood flow. So if you don't have perfusion, it makes it more difficult for optically based sensors, at least. Electrically based sensors have their own problems and areas for consideration. We have this heat image of a hand. Somebody's hand and arm is very, very cold. Of course, that becomes more difficult. We're pretty successful in that, but there are times that, especially with the arm, not so much the ear, that there may need to be some blood flow get going during a session before we get really great signal, but most time we overcome that with our algorithms. And then, of course, I've already talked about sensor location, the ear being in one of the ideal locations. The arm being, depending on where you're at, the arm, that varies. Down on the wrist is pretty good for a lot of exercises. Some exercises, of course, as you can imagine, give the wrist a little more difficulty. But the forearm and the upper arm are actually pretty robust. And then just knowing your protocols, knowing what happens with your biometrics. This is describing this crossover problem. If you can imagine this green line here, that's step rate, and then the red and blue line are heart rates. So that we're trying to pull that very small heart rate signal out of a lot of noise, and one of those big noise sources is step rate. So as you are walking or running and the heart rate's going up and kind of crosses through your step rate, that's a difficult time. And just something to keep an eye out. I've seen all sorts of biometric devices, not just optical, have trouble related to step rate because it's such a big noise source. Talked a little bit about protocols, but you've got to think about them and your use case. You just can't sit at the desk or go walk around the parking lot and say, wham, bam, I've got a biometric sensor that works. You've got to test. We ask anyone, even media reviewing anything, to test with at least 3 people. In our lab, we try to test with 20 different people on every variant of every device that we have. Once you get to 20, then you can start to really make some decisions. If you try to start making decisions early at n equals 1 or n equals 3, to some extent, you can be led down the wrong path. So that protocol is very specific. A device, a location can be pretty good in one thing, but not so great in other situations. It's just a list of some of our protocols that we use in the lab. Of course, we do use all the CTA protocols. Our go-to protocol is an 8-minute dynamic treadmill protocol. We test all of our devices on that, changing heart rate, changing step rate. They're walking and standing and running. We have sunlight testing. We have activities of daily living. Of course, we have resting tests and bike and intervals, rowing ergometer strength, high intensity intervals. People have questions about, well, how good is it during high heart rates, and how good is it the heart rate ramping up or in the recovery? So we have data to support all of these things, and swimming. And swimming is, of course, a special case. There's mechanical design that are big concerns in swimming with the interface of the water, how the hand, if it's on the arm or the ear, is interfacing with the water. And of course, Bluetooth doesn't work in water, so that's even a bigger concern. Well, I wanted to circle back around to our reference devices. This is 3 different data sets comparing 2 chest straps on the same people. So these are 3 different studies that we did. Each study had at least 20 different individuals. In each study, they had 2 chest strap heart rate monitors on at the same time, and we randomized the position and didn't let them bang into each other. And this is the results. Chest strap heart rate monitors are very accurate. They're not 100% accurate, and I wanted to give us a baseline of what are we comparing to here. What we see that 94-ish% of the data is within plus or minus 5% of the other chest strap. So all devices, we're working with humans here, but all devices have some error in them, depends for a variety of reasons. But just really to baseline your benchmark devices, no matter what it is, and kind of report that out. I'll mention that one more time in a minute. In our own data analysis, we look at means and standard deviations, we look at the bias, we look at mean absolute percent error, which is what the CTA protocol recommends, and then we look at that frequency distribution, which I just had kind of shown you with the chest straps, of what percentage of the data is within a certain windows. And then kind of more traditional Bland-Altman and correlation as needed. We also separate it into moderate and vigorous intensity. So we look at our accuracy at less than vigorous and then in the vigorous categories, and those are defined by the American College of Sports Medicine and American Heart Association, so we follow those guidelines. Some areas for consideration, I've already talked about a lot of areas for consideration, but some areas of consideration are, number one, I highlighted this in orange because this is my soapbox topic, is our baseline errors. Did I remove any reference device? And you look at the published journal articles in this area, and the researcher using ECG as a baseline, which is great. They might be using a chest strap as a baseline. And you're led to believe that let's say they test 40 people. You're led to believe that in those 40 people, the reference device, say an ECG, worked perfectly for them all the time. And that is not possible. It may be possible on a very rare occasion, but I rarely see anyone reporting the percentage or the number of times that they had to throw data out from the reference device. And that's a disservice to the device that they're testing, of course. So we throw data out, we report how many data sets we throw out, and then we report our data with the all good reference devices and show the accuracy of the device under test related to that. But it is important. This lower left, that is a chest strap in the blue there, and that is not correct heart rate. So we would throw this data set out and we would report that. But other things to look for, time to lock on the heart rate, and that's an example here. You can see the orange line. It took a little time for the heart rate of the blue line and the orange line to come together. And data alignment and or latency in the calculation. So you can see that this data in the lower right is offset a little bit. And that might need to be aligned a little bit more. You want to report that latency, but when you do your statistics on accuracy, you want to line that data up and look at the actual performance. And you combine the latency data, if it's there, with the performance data to get a clear view of the performance. Now, just a few use cases in the last couple minutes. I've got 6. I'm not going to go into a lot of depth. The key takeaways from these use cases are these are pretty simple use cases. I think there is plenty of literature out there, and you get a couple people thinking along the right path, and you'll come up with some great use cases that the normal person and the athlete could benefit from. And this is a really simple one. The American Heart Association, most of us probably know about this, recommends 150 minutes of moderate or 75 minutes of vigorous exercise per week. And we're not talking about exercise. We're not talking about going out and running a 5K. We're talking about just being physically active here. We're talking about everyone living should be getting this kind of activity. And we can use heart rate. We can use accelerometry. We can use rating of perceived exertion to quantify this moderate to vigorous exercise. And it allows us to kind of go beyond, or at least supplement, this 10,000 step thing that's been around for a long time. You can provide goals for people and get it from a variety of sources. So this is one that one of the working groups for CTA, this is one of the kind of related to the standard that we're doing on intensity, and just outlining that and kind of going beyond the 10,000 steps. So that's a use case that I think hasn't been done all that well, and not necessarily widely available, which can be put in place. The important part about this intensity is that if you're going to use heart rate, it is important to know what your quality of signal is, know when you're measuring correctly and not measuring correctly. Same thing kind of with accelerometry. Was the person really active, or were they on a train or something? Because you want to be accurate when you're putting the activity into the bins and actually counting it, because of this moderate and vigorous giving so much benefit to health, overall health. And then when we go, that American Heart goes beyond the 10,000 steps. And then if we say, well, for somebody that's exercising, 5 days a week, and they may be out jogging or something, or doing spin classes, they will meet the American Heart guidelines pretty quickly. Well, we can go beyond the American Heart as well, and we can do a distribution and amount of activity, volume, and intensity, and that can optimize performance. There's research out there that shows kind of optimal amounts of exercise in different zones of intensity. So I want to get 15% in this zone and 70% in this zone on a weekly basis. And we can look about how they polarize their training, perhaps, like how much time. Is it average heart rate, or were they going intervals where the heart rate's up and down, both of which may result in the same average heart rate? So those are kind of going beyond the American Heart guidelines. Overall stress status. Heart rate variability, we've talked about a couple times. It's a way to monitor stress. It's a way to monitor chronic disease and age to some extent, or cardiac age. But if we take this measurement, just like a resting heart rate measurement, on a daily or almost daily basis, we can start to see trends that happen over time. And this stress, of course, as we all know, comes from many sources. It may come from activity, but it may come from a poor diet, poor sleeping, stressful job, stressful life, whatever it is. Those all lead into how I'm able to perform on a daily basis. And so watching this trending, using the correct statistics on those intervals between heartbeats, and that's the key, is using the right statistics, filtering the data properly. You can use heart rate variability and monitor that from day to day, week to week, month to month, and get some good insight into that, especially if you have other inputs from the person, but that's not necessary. And then along the same lines, heart rate variability does change as we age, and that changes for, again, all sorts of reasons. Chronic disease brings about changes to heart rate variability, and of course, they're not great changes to heart rate variability because they're indicating that chronic disease is coming on. So there are ways, and there, again, research that's out there that supports estimating cardiac age by means of heart rate variability inputs, and then output some good user interface experiences for the people. Of course, there's a lot of storyboarding and thought that needs to go behind all this. These are simple use cases, but they're complex to implement. And I think really that's why a lot of them don't come out, is that it can be expensive to really get to a simple interface for a user that is smart behind the scenes. An estimation of human core temperature. Right now we're doing that primarily with just using heart rate, changes in heart rate over time. It's meant to be used during work situations, meaning exercise or military situations, and we monitor. You can estimate that core temperature, and there's a very good correlation between your internal core temperature getting to a certain level and decreases in performance or ability to do work output. So you can monitor that. You could estimate when that core temperature may be reached and try to do things for the person, or suggest things for the person to decrease that rise in core temperature during that work output and allow them to perform work for longer periods of time. And then a sixth one is one that is probably the most difficult to implement in these six, but diet planning based on activity metrics. Knowledge of previous and upcoming trends allows us to recommend diet strategies. So if we know this person is doing a lot of intense work in the field, or if we know environmental temperature, we could estimate all sorts of things, but we could suggest things related to macronutrients, on carbohydrates, fats, and proteins. People that do more intense exercise do have a need to recover from intense exercise or work, do have a need to recover from those activities so they can do it again when they need to, if that's quickly, and that may need more carbohydrates if they're doing it, and then knowing the level of protein and that sort of thing. So you can make overall diet recommendations based on this, especially in the macro. In the micronutrient level, that's possible as well. Of course, there's lots of micronutrients, and people try to say some are more important than others, and they are, but that becomes a little more complex, and they're not as helpful and beneficial as, say, the micronutrient or macronutrients. Well, the key takeaways from this are really accuracy is critical to rewarding that user experience. We don't want to provide the wrong biometrics, no matter what it is, whether it's heart rate or step rate or sweat rate or anything, or temperature, and then have use cases that rely on this and not know that those outputs are accurate. So here we, again, have these figures of merit. We encourage our partners to implement and think through the process, the user experience. Validation takes planning, lots of planning. It takes a lot of thought, intuition, and experience on it. Again, it's not a simple process. It is pretty complex. You've got to think through a lot. You've got to do a lot of testing. Even if it's on yourself or multiple people is necessary. So it's not just a benchtop thing. There is no benchtop test for biometric sensors that will give you the same outputs as what humans have. And then the use cases should be simple. Keep it simple on these use cases. I haven't been overly blown away by too many user experiences. And follow, it needs to be simple and follow this support that research has provided us. There's lots out there. It takes a while. It takes a while to wade through it and determine what's good and what could be usable and not usable, and then doing some test cases. But it's there. We're slowly moving that direction. Lots of people have thoughts. I just don't see a ton of in-product user experience action. That's all I've got for you for today. We've got a few minutes to do questions and answers, and Casey's going to help me with that if there are any.
Yep. Let's see, we've got a couple here. Someone mentioned, and I think you touched on this throughout, but someone mentioned in the PerformTech app, there is a quality score. Is that an indicator of accuracy? Can you explain that more?
Yeah, so the quality figure of merit it can be an indicator of accuracy. It should not be used on a second by second basis. So it's scored. It's scored 0 to 100, but that score is not linear. We do have zones that indicate that we have a signal that we're confident that we're going to be producing a biometric that is accurate. But again, it's not meant to do a second by second. It needs to have some windowing and that sort of thing. And it's dependent on your use case. It's depending on the sensor location, and certainly reach out to your contact if you're testing a device with questions about that quality score. But it is quality of signal. It is not linear from 0 to 100, and it does tell us whether, in a lot of times, whether we're getting good enough signal for that metric.
Perfect. We also we got a question about whether you can get a copy of the presentation, and the answer is yes. Following this webinar, I will send around a copy of the slides and a recording of today's webinar. Let's see. We also got a question. Can you talk more about how PPG technology accuracy is affected by skin tone?
Yes. Well, the darker skin tones absorb more light, of course, as we know. Black, black coloring absorbs light. White coloring reflects light, and that's really the basis of this whole thing. We at Valencell have really overcome that, and it's not much of a problem. Where there are some problems with, if someone has a sleeve of tattoos, but even in that case, it's somewhat rare that someone's going to have enough kind of completely black ink that causes problems. And the CTA protocol does ask for a certain percentage of the participants to be high on the Fitzpatrick scale and a certain percentage to be low on the Fitzpatrick scale. I will say this though, I think that for the most part, people worry about skin tones more than they should. From our experience in the lab, there are people that are difficult to measure that have very dark skin, and they're difficult to measure that have very light skin. And there are people that are very easy to measure that have dark skin, and very easy to measure that have light skin. So there's other things going on with like connective tissue and just general genetics between people that are causing as much difficulty than any kind of skin tone concerns that we would have. But it is good to test that, and that's why we continue to test it, to show to our partners, yes, it's working. It's kind of the same thing as the sunlight. We go out and test in the sunlight. We're never really all that concerned about going out and testing in the sunlight, but it is part of our normal testing suite.
Awesome. We have another question about accuracy of the sensor. Does hydration level affect the accuracy?
Not really. I think that it's not going to affect the accuracy, only in that if someone's severely dehydrated, in the same way that someone's cold, if you're severely dehydrated, you might have some constriction of the arteries, the arterioles that are trying to bring the blood supply to the core of the body, and of course then you might have lower perfusion at the hands. But that's an extreme case. So really, from a hydration standpoint, you're still going to have the blood flow going throughout the body. But if someone's severely dehydrated and if their blood pressure is very low and those sorts of things, then the signal does degrade, while we still may be able to pull the biometric from there.
Great. We'll give everyone a couple more minutes to get their questions in. Here we go. What is accuracy of benchmark sensor differences while physically active versus during sleep?
Well, the benchmark, we have white papers there's some white papers on our website, but those are not the most current white papers that we provide. Going to be more robust than say on the wrist, but when overall the performance is very good. And again, we've gone through and looked at in those performance papers, how many of the reference devices or in the baseline devices did we have to remove? Then we look at the performance, and then we actually say, well, how many obvious failures were in the device under test, and we remove that. And then we look at the two devices performing well together and provide that statistic. But our goal is to get at least 85. We would ideally like to have 85% of the data within plus or minus 5%. That's use case dependent and all of those sorts of things.
Great. Thanks for sticking with us, everyone. It looks like we have a few more questions. Someone asked about interference of two PPG sensors that are close to each other on the body.
Well, the wavelength of that light is not going very far. So if you have, if you have two PPG sensors in close proximity, I would hope that it's underneath some sort of patch or something. It really shouldn't be on the wrist. If you're testing a couple devices, I never mentioned this, if you're testing a couple devices, they should not be on the same arm, because one could cut off the blood supply to the other. The other thing is one's higher on the arm than another. You're going to get different performances. They could bang into each other. But the wavelength of the light is not going to really be a problem. Even if the wavelength reached over to the other one, it might just actually supply more light to the other one after it had gone through tissue. But that shouldn't really be a worry, but you shouldn't really have them on the same wrist. Generally, having one on each wrist, the left and right, there isn't any difference between those two, so you can have one on each. There are some people where we see different performance on their two arms. When you get to like 20 people or so, it kind of filters everything out. So we will do some testing where we'll switch wrists, and our lifestyle testing, of course, we're cognizant of whether it's on your dominant hand or your non-dominant hand. A lot of times we are asking people what arm they wear a watch on or something like that.
Great. Someone asked, is the CTA standard applicable for a wearable medical device that measures physiological parameters as well?
I guess it would be my starting point. It depends. The CTA protocol or standard that I talked about is exclusively heart rate. So and it has a resting heart rate protocol in there. It's a starting point. It's not intended for medical devices at this point. I will say that if you look up the standard for electrocardiograms, they're using an absolute 10%, I believe, on their accuracy standard, which is a huge window, especially when you're in a resting situation. I would expect a lot better accuracy than that, but that's a medical device. And then we have the same 10% is that absolute 10% is the performance standard within the CTA document.
Great. Let's see. Someone wanted to know, is motion compensated in the Valencell sensors?
Oh, of course. I mean, that's what we do. That's our specialty. All of our algorithms are centered around motion tolerant PPG, motion tolerant optical sensors, and that's the foundation of our company.
Great. And then let's see. Someone has a question about blood pressure. When validating blood pressure from a wearable device, what reference or gold standard device do you use, and how frequently do you measure?
Well, the standard for there is a standard out there for cuffless measurements. There's a standard out there for automatic blood pressure cuffs, and that protocol is generally sit down and rest, and then the reference is actually manual blood pressure using a dual-headed stethoscope. So our reference is manual blood pressure. We're actually listening for Korsakoff sounds. We also are using when we're using the non-invasive sensor, we are doing manual blood pressure, and we're also using two different automatic blood pressure cuffs. We do have trials where I go and collect data, and we're using an arterial line. That is, of course, as you can imagine, very difficult to get that population, but we do have experience in working with some of our partners that are involved in some surgical situation that this is already happening, and I go in there and collect some data during the surgery, at which time blood pressure is changing, and we're getting that actual pressure transducer in an arterial line, which is awesome, and it's continuous, so it's not just the one-time thing. But our general protocol for all of our stuff is sitting and resting and taking the blood pressure measurements, collecting the data from our optical sensors, and we'll repeat it again, and then those people will come in multiple times. There are a couple blood pressure standards out there that are pretty helpful.
Great. That looks like about it. I know we're getting near the top of the hour here. If you have any questions that we didn't get to address today, like I said, we will be sending around this presentation. It has Dr. Eschbach's contact information here. You can also always reach us at info@valencell.com. And with that, I guess we'll wrap up. Chris, thanks for being here today.
All right, thanks for everybody for attending. If you have questions, let us know. Have a good day and a good weekend coming up.